Hello, everybody. Thank you for tuning in today for our second installment of our virtual Parkinson's Awareness Month programs. Today, Dr. Adam Sarkar and Dr. Zafar Zamir. And while people are sort of trickling in, we'll get going in just a little bit, but today we're going to be talking about the surgical options in Parkinson's disease. And I know that for those of you that know me, my name is Dr. Jill Farmer. For those that don't, I'm Dr. Jill Farmer, and I am the director of the Movement Disorder Program at Global Neuroscience Institute. And in our office visits, we talk about options for Parkinson's all the time. And when surgical options come up, I can talk through who might be a good candidate and why you're a good candidate and why one particular option may be better suited for your symptoms. But I wanted to have our surgeons and proceduralists on today so that we could talk about the procedure itself, because that's something that I can't get into the nitty-gritty about to the same extent. So we're going to have a dialogue today about that. As people are logging in, the numbers are going up. We have 77 registered for today. So we're currently at 41. So we're more than halfway there. As people are logging in, just to go over the program for the month, we're doing a lunch and learn basically every Friday for Parkinson's Awareness Month in April. If you missed last Friday's, it's recorded and you can view the link at any time you'd like. Today's presentation will also be recorded, and you can still register for next week, the week after, and the week after that. We have 3 more coming up. Next week will be a virtual booth session, which means that we have Parkinson's awareness advocacy groups like the Parkinson's Alliance and the Parkinson's Foundation of New York and New Jersey, as well as our sponsors, which you see scrolling through now, some medical device companies and some pharmaceutical companies that we will host in different breakout rooms, and we'll rotate through the breakout rooms so you can learn some more about what's available and ask any questions you might have. The week after that is talking about a multidisciplinary team approach with our rehab partners at Robert Wood Hamilton and our neuropsychologist. And then the week after that, Dr. Sarkar and I will be back for a Q&A. So while we encourage you to ask questions today via the chat function or the Q&A function, if we don't get to them, or if you think of something later, either save them for the 30th, or you can reply to the email that you register with the link, and we can document the questions and answer those on the last Friday. So with that, I'm going to stop my share. Hopefully everybody sees us in gallery view, and I would love to let Dr. Sarkar and Dr. Zamir introduce themselves. Oh, Dr. Sarkar, I think you're on mute.
All right, then I will start.
Okay.
Yeah, that sounds better. So I'm Atom Sarkar. I'm a colleague of Dr. Farmer's. We both work at Global Neurosciences Institute, which is part of Drexel University, where we have our faculty appointments. I have an MD and a PhD and have been doing deep brain stimulation work ever since it was actually approved by the FDA in 1997. My residency started in '98 at the Mayo Clinic, and so this is one of the things that I do that I think is the most exciting thing that I do and brings the most amount of functional restoration to my patients. So I'll just leave it at that and let Dr. Zamir introduce himself.
Hi, I'm Dr. Zamir, gastroenterologist. I practice out of Hamilton, Robert Wood Johnson Hospital in Hamilton, and my practice name is Hamilton Gastroenterology. And most recently, I've been working with Dr. Jill Farmer doing this DUPA procedure to do the delivery of the Parkinson's medications in the small bowel, because as you know, that delivery of the medications sometimes result in the better relief of symptoms. So we have had a few patients that we share, and I'm honored to be here, and I'll be happy to take any questions after the seminar. Thank you.
Thank you both so much. So not everybody who is logged in may be familiar with DBS and Duopa. So I'm just going to play 2 short videos really quickly so you can get a visual of what it is that we're talking about. And then after that, we'll open it up to questions. The Duopa video is from the website, from the company's website. They have a bunch of patient testimonials. And I thought this was a nice video because it shows the patient wearing the pump, how they manipulate the pump, why they chose to get the pump. It also shows a live patient that has Parkinson's and the symptoms that they're managing, and he's a little dyskinetic in the video, and you can relate to some of the mobility and movement issues that he might have. The second video that we're going to show is actually a patient of Dr. Sarkar's in the in the operating room, and that always gets a really nice response. So here is the Duopa video.
These are real people who, along with their doctor's advice, decided to choose Duopa, carbidopa, and levodopa. They have volunteered to share their story with you. Individual experiences may vary. These are their stories in their own words. Only you and your healthcare provider will determine if Duopa could be right for you.
I'm Paul. I'm a father, grandfather, husband, and brother. And I have Parkinson's disease. From the time I got the first symptom until I saw the doctor was at least 6 months, maybe 9 months. I brushed it off. Oh, it's nothing. Oh, people do that all the time. And I thought every excuse I could. This is denial, actually. And I thought I should see a doctor. And he examined me, went over my history in great detail, and finally pulled his head back a little bit and said, well, if you ask me, I think it's Parkinson's disease. The next couple months after my initial visit, I was really shuffling my feet. I'd make every excuse I could think of. New shoes, the carpeting's just got cleaned. I'd make all kind of foolish excuses. And I had to go back to my doctor and said, should we start treating something? I figure I should tell my family pretty soon. I'm rather sure this is the diagnosis. And how and when should I do that? So I said, I want you all to know that I have a significant problem, a mild significant problem that's going to bother me. It doesn't bother me at all now, but it might bother me in a few years. And it's a family kind of disease, because once one person in the family gets it, the whole family has that disease. I was getting by with increasing symptoms, told my doctor what symptoms had progressed. So I took a lot of medicines. I couldn't count how many pills a day. If I cut back on my pills, I'd just get rigid and stiff and couldn't walk at all. So I was looking for some kind of answer, for something to help. And I heard of a medicine that might be of benefit. It's called Duopa. The first night after the surgery, I didn't really feel much because I was anesthetized and disoriented and stuff. So I just lay in bed and did what they said to do. Next morning, I got hooked up. The medicine's flowing. Doctor was there at 8 a.m., punctually checked me, checked everything. Then they showed me how the pump worked, a lot of buttons and numbers and stuff, and I'm ready to go. I have a typical day which I can describe as follows. As I wake up each morning, the rules are I have to disconnect every night, which I do, and then I reconnect every morning at about 6 a.m. That's my regular routine. The medicine has to be refrigerated, so I keep it in a nearby refrigerator. The medicine is in a cassette that gets attached to my pump, which then I connect to my tube. Each night at about 10 o'clock, I disconnect the pump from the tube, flush the tube with some water, and then remove the cassette from the pump, discard the cassette, and the pump's ready for the next morning. The inventors of this medicine put in an extra dose, which I'm allowed to take in 2-hour intervals. When I dip down into a valley, I'm sluggish and droopy and can't carry out any task. So I have to be careful how I use the extra dose, and I report them into my doctor, not every day, but every 6 weeks. How much are you using your extra dose? So we have an ongoing dialogue. Since starting Duopa, I've experienced less off time, but I'm still short on some things I can't do. There are a few favorite activities I've picked on, things that I can handle easily, so that's where I focus my attention. My physical therapy program keeps me physically active because otherwise I sit in a chair and just watch the world go by. But my physical therapist and other people around me are encouraging me to get up and go around and do things. They're right, I should, and I do. Support of the family is hugely important. Doctors are important, nurses, all those people are important. But family support is hugely important in this particular disease. I can enjoy time with my family. My wife, of course, is living here with me for 51 years. We've been together, and time with Joan is very valuable to me, and we enjoy a lovely life together. Our son and daughter are terrific kids. We have a real good time with them. I'm glad that I have Duopa. It was the right drug for me. I've been so lucky to have this because it came at a time in my life when I really needed it.
So that's Duopa. And like I said, I thought it was a nice rounded out video because it shows a lot of what it takes to wear the pump and how to manipulate the pump and things like that. The next video is for DBS, and this shows you the setup in the OR and what that experience will be like. And you'll see that this patient's a little different in that he has a much more pronounced tremor.
We talked about this in the preoperative area, in our pre-surgical area, in the clinic. You're fine with us videotaping you and showing your face, correct? Okay, we appreciate that because I think it will help people. What we're going to do is periodically throughout the case do some other videotaping to make sure that we're able to document the success of your procedure. Okay, Dale? All right, we're going to get started now, Dale. Thank you. Yep, that's below target on the. We're one below target. Okay, we're in the right brain, right side of the hemisphere, and we're in the posterior tract. Yes. Okay, we're going to go on now. 100 milliamp, ready and on. Okay, wow, Dale. Sweet. That's a sweet spot, baby. How do you like that? That's not so bad. You're going to be drumming again. Oh, let's see. Where are you at now? This is 2 milliamps. Okay. Go off? Yeah, go off now. Oh, now we're off. Off stim. Then go back on. Okay, we're going to go back on stim, Dale. You might feel something. Okay, on. Tingling. Tingle. Wow. All right, Dale. That looks like we're getting really darn close. Yeah, it's awesome.
Dad, honey.
What are you doing, sweetie pie?
What are you doing?
Giving you a phone call.
So, I mean, he's making a phone call during surgery, so that always gets a chuckle. But let me stop share here. And then we will open it up to questions. So you guys can type them into the Q&A in the chat, and then we'll get started. I know Dr. Sarkar and I have done a couple of programs about DBS. So I'll actually start with Dr. Zamir because you might be a little less familiar with that. So talk us through what the procedure itself entails, having a PEG-J placed. Oh, you're muted.
Thank you for reminding me. Thank you.
No problem.
So as a gastroenterologist, doing a PEG procedure, which stands for PerKittiness endoscopic gastrostomy tube, is something that I've been doing since my first day of training, let's say. So in that procedure, basically patients come in fasting. They're given an IV line, they're sedated, and then we put a camera that's called endoscope for the patients, and look in the stomach, make sure there are no growths, ulcers, etc. And after that, it's a 5-minute thing. We make a little small cut on the stomach wall. We have a way to find the stomach through the abdominal wall. We shine a light, find the opening, the area where we'll make the opening, make a little cut, and in the end, we pull a tube, which is called PerKittiness endoscopic gastrostomy tube, and that comes out of the stomach wall. For the DUPA procedure, as you know, that we have an extension, because from my understanding, and of course you can express this better than I can, the Parkinson's medications sometimes don't get absorbed very well from the stomach for a variety of reasons. Maybe it's their underlying gastroparesis, or maybe in that, those few patients, the medications are binding with the food and they cannot space it out well for a better constant absorption, and they're having these breakthrough symptoms. So this DUPA procedure does is we have an extension from the stomach to the small bowel, past the stomach, where there can be a constant infusion of these medications through the pump, which you just showed. That way, the patients can have this constant delivery of medications into their small bowel. As far as the patients go, they are sedated or sleeping for, I want to say, about 20, maybe 25 minutes. Once they wake up, they are ready to go home within half an hour. They can start using the pump later the same evening. They can, in terms of their oral intake, what they are limited to is only that they come fasting to us. Once we are done with the procedures, they continue fasting for about 4 hours. And after that, they can continue, they can start clear liquid diet. And of course, they can take all the medications. And next morning, they can go around and have their normal diet. And at the same time, they can continue to use DOPA for infusion of medications, as you described.
Prior to the procedure, do you recommend having them come in for a consult, or is this something that if I decide DUOPA is okay, they can just schedule the procedure with you?
So it's an invasive procedure. It involves putting the patients under. We make a cut. There's a risk of perforation. There's a risk of bleeding. So if at all possible, it's best that patients seek a consultation first, so we can talk to them about the risk benefits, what is the nature of this procedure. We can look over the medications and advise them holding a medication or two for a day or so if needed. And I think that way, patients have a better understanding of what the procedure entails and what would be the recovery like. And in case something does not go well or according to their expectations, they have a person to call and to walk them through that.
Absolutely. So, Dr. Sarkar, what's the pre-op and operative day like for someone with DBS?
It's a lot more involved, as you are aware, and the contemplation to get them to the OR is also more involved. So absolutely, they've been seeing you. They also have to see our neuropsychiatry team just to make sure that there is nothing that we might miss that would make the patients worse after a surgical procedure, in particular because this is a brain surgery. And then once they have the clearance from our neuropsychiatry group and also from you, Jill, that you feel that this is their next best option, or this is just their best option, then they come to me, because then I talk to them about sort of the real nuances of nuts and bolts about how this surgery goes. It's not a one-day procedure, it's a multi-day procedure. There are a lot of different ways to do DBS surgery. We've focused on a way that we feel maximizes patient comfort and satisfaction and gets them the best kind of outcome. So if you were to come to us, you'd have 3 different encounters, each of which lasts either a day to overnight. And I can get into more of that later as the questions kind of bring themselves up.
Sure. As far as taking meds and things like that, are they able to take their medicine the morning of the procedure, or do they also have to come in fasting?
Well, for my procedure, they there are three different components. One component is what I call sort of the navigation or the Google mapping component. And that component is under general anesthesia, so they do have to be fasting. They can take their Parkinson's meds, but they do have to be fasting. There's a second component, which is the operative component in the OR, where you saw that video, which is very much with a patient awake. And again, our anesthesiologist would have a cow if you ate, so that you have to be fasting. And in particular, then we want you at your worst. I know that's scary for many patients, but we don't want you taking any medication for Parkinson's because we want to see your rigidity or your tremor or whatever your malady is that affects you most with Parkinson's to be at its worst so we can see how much we can improve it. And then there's yet another procedure where now you have wires in your head and they have to be connected to a battery. That one is entirely asleep. You also have to be fasting, but you can take your Parkinson's medication at that time.
Okay. How about discomfort post-operatively? That's a question that I often get. So Dr. Zamir, what can they expect as far as discomfort after getting the peg placed?
So the incision is rather small. It is about 1/4 of an inch. Most of the patients will have very little soreness. A local anesthetic is also used before we make a cut, so that local anesthesia works for half an hour to 1 hour. After that, it wears off. I have to say that almost never any patient has to take pain medication other than a regular Tylenol for the discomfort they may have. And surprisingly enough, this soreness settles down within 12 hours or so. Because remember, the pain is only from the cutting of the skin. And that incision is very, very small. So whatever pain fibers are cut, they are in that 1/4 inch incision. So the pain and discomfort is usually not an issue. I almost never get a call back for the pain. If I get a call for the pain, that means something is not right. And there are a couple of things that could have gone wrong, which is again, very, very, very unusual, which is that from the incision, sometimes there could be a bleeding under the skin, which can cause a bleb. And that bleb under tension can cause pain. That happens within the first 24 hours. If it does not happen, then it's not going to happen. And the second time that the pain happens, which is a few days later, if it does, and again, not very common, it's an infection. And if that happens, there will be more than pain. There will be a discharge, crusting, and the patients or the family would know that there is something not right. And majority of the time, I would say 90 to 95% of the time, it can be taken care of by a local application of a cream. Sometimes we do have to use oral antibiotics. The chance of infection, if the PEG site is taken care of in the right fashion, again, is a very small, I would say less than 10%.
Okay. And then Dr. Sarkar, the patient was awake during the procedure. So we often get that question. Is it painful? Does it hurt? So can you discuss that a little bit?
Yeah, it's one of those things that it's remarkable when it happens. It's a thing that has many people apprehensive, but I can tell you that we've taken folks from certainly as old as 80 to as young as 8 and gotten them through into the OR. We numb up the scalp. We make folks just a little bit sleepy, but not a lot. And then once their scalp is numb, then they're fully awake. A numb scalp doesn't feel anything, and the beauty of the brain is it also doesn't sense anything. So, you know, Jill, you might remember one of our earliest patients was during the case, they were just, online shopping with the nurses. So it's a bizarre sort of thing to conceptualize, but once you're there and in the moment, they're just perfectly fine.
And I will talk a little bit about the awake portion as a neurologist, as a movement disorder specialist. There is an option to have this procedure done asleep, but I don't think that that is the most appropriate way to do the procedure, because part of the things that I want you as a patient to get out of the procedure is improvement in your symptom. And by being awake, by being able to see your symptom in real time and be able to manipulate it with the placement of the lead and the amount of stimulation that's given, is an extremely valuable piece of information that can be theoretically duplicated through computer models and things like that in an asleep DBS procedure. But I think that having the patient awake, since it's not uncomfortable, it's not disconcerting, it is something that provides a wealth of information, is in my opinion, the better way to have the procedure done. So I get that question often. I hear there's an awake DBS and an asleep DBS, and I still will guide patients to consider the awake DBS, because I think the information that you get intraoperatively is that important for the continued symptom management going forward.
Yeah, I would really agree with that. And I would just reiterate that I think you have only one opportunity to do things right. And I think that that happens in the operating room where the patients are awake. Again, it seems a little disconcerting, but there's so much information that we gain from that. And what patients may or may not be aware of is that we actually listen to their brains when we're doing these surgeries. And much like if you were to travel from France to Spain, you'd hear French and then you'd hear Spanish. Different parts of the brain have different languages, so to speak. And since the targeting is so precise and it requires hitting a 6 millimeter target, we listen to the brain, we have the patients awake, we look for aberrations that might occur. And this way, Jill, we give you and the patients the best opportunity for having an excellent postoperative result.
Absolutely. And you mentioned this is another difference between Duopa and DBS. You had said that there's one chance to get it right, because typically this isn't something that is reversible. Leads can be taken out, things can be repositioned if necessary, but that's not necessarily the goal. It's to kind of do it in one shot. So that's different from the PEG-J procedure. So Dr. Zamir, the procedure, the PEG-J is reversible. You can remove that fairly easily, correct?
That is correct. However, a technical thing about these procedures is that when we do make a hole in the stomach, it stays there for several weeks. So I do recommend my patients that once we put the tube in, it should stay there for at least 6 to 8 weeks. The idea is so that the stomach wall gets attached to the abdominal wall. Imagine that if the tube is placed and for some reason it has to be taken out within a few days or in a week or two, the stomach wall will fall away from the abdominal wall and may have a small hole in it, and it can leak gastric contents from that hole. Versus if we allow the full healing for about 6 to 8 weeks, the tube can be removed. The opening or the stoma closes within 24 hours. We just put a gauze there, and a couple of days later, you cannot even tell that anything was there. There's a small scar left. But for the once we are committed to put a tube in, we are committed to keep the tube in for 2 months, unless if it accidentally falls out, that's a different story. Then depending on the timing, we have to address it accordingly, but we do advise to plan for at least 2 months.
And just from learning to live with the device, as you saw in the video, it's not small. It is external, whereas DBS is all internal and under the skin. Not only for the healing property of the PEG-J itself, but just the learning curve of getting used to walking around with the pump attached and how to manipulate it. I also tell my patients to give it about 2 to 3 months, because it can take that amount of time to really get used to it. It weighs a few pounds. It doesn't have to be worn the way that gentleman wore it in the video, which is in a crossbody bag. It can be worn in something that's on the belt, more like a fanny pack, or in a tighter vest closer to the skin. Doesn't have to be worn in anything that AbbVie provides. It can be, if you're good at sewing or little fashion hacks. You can put pockets on the inside of clothing and wear tighter bands around the abdomen or the chest to keep the pump in there. But it does take a little bit of time to understand how to wear it, how to use it, and how to feel comfortable with it. We did get a couple of questions, so I'll shoot over to those real quick. If the most bothersome symptom of Parkinson's is extreme stiffness, especially in walking, how can the doctor handle this during surgery? So good question. I'll let Dr. Sarkar answer that one.
So we always show those videos where people are generally shaking, and the video that Dr. Farmer showed, I think, had a little bit of a delay, so you couldn't see the profound shake that that patient had. But he couldn't barely hold anything. He never used a phone because he's dominant left-handed, and the phone would just fly out of his hand. So that's just a very dramatic video that we show, but the stiffness and rigidity of Parkinson's, it's a reality. And that's one of the beauties of the procedure. I think DBS really can deal with 3 out of the 4 cardinal symptoms of Parkinson's. There's a stooped posture gait that might be the least amenable to any kind of therapy. But stiffness and rigidity are things that we can absolutely affect. As a matter of fact, the patient we just did on Tuesday, that was his prominent problem. It was stiffness, slowness, and rigidity. And you can see once you turn on the electrical systems, it's almost as if something just relaxes and then they can start moving.
And so obviously they're not going to be able to get up and walk during surgery, but think about how I examine a patient in the exam room. I check their stiffness and rigidity by moving their joints around. And that's the same way that it's done during the procedure in the upper extremities and the lower extremities. So you can still elicit you can still see a symptomatic improvement in that level of stiffness, even if the patient's not able to walk during the procedure. Another question, how many meds can be eliminated after the pump is active? My husband takes Rytary, rivastigmine, mirtazapine, and Belsomra. So that is, I'll handle that one. The pump is meant to take over the carbidopa levodopa medicines that you are taking orally. So if you're taking 1 tablet of carbidopa levodopa every 4 hours, or you're taking 2 tablets of carbidopa levodopa every 2 hours, while the pump is running during the day, you no longer have to take the carbidopa levodopa medication. But if you're taking other medicines to complement that for Parkinson's disease, you may or may not still need to take those. So if you're taking a recycler, like a COMT inhibitor or an MAOB inhibitor, since the medicine is being continuously infused, that may not be necessary to continue because you don't need to keep it around any longer. It's going in at a constant rate. But if you're taking something like a dopamine agonist, Mirapex, Requip, Nupro, something like that, those medicines have other benefits just besides the motor symptoms of Parkinson's disease. They can help a little bit with mood, with energy, things like that. So that's a conversation to have with your doctor to see if you need to come off of those medicines or if you would keep them on to some degree. Medicines like rivastigmine, mirtazapine, and Belsomra, those are really to help with sleep and memory. So the Duopa pump would not have any impact on those medications, and those would be things that you would likely either still need to stay on, or because dopamine and sleep have a funny relationship, if the continuous dopamine that you're getting during the day helps reset that cycle in some way, you may not need the same medicines for sleep. But again, that's on an individual basis to see exactly how your medicines are working for you. The other question was, after DBS, is medication still needed, and how long is the procedure and recovery? So Dr. Sarkar, I'll have you answer the procedure and recovery, and I'll talk about the medicines in a sec.
So I'll speak a little bit about the medications and only say that what I always tell patients are that our goal, our combined goal in working together, Jill, is that we give patients the best long-term outcome continuously, so they're as quote unquote on for as long as they can be and off for as little time as possible. So that usually means that if somebody's coming to me and saying that I want to be on no medication, I usually say that that's probably unlikely But Dr. Farmer, working with both the electrical therapy and the medication therapy, can probably find a way of at least reducing medications. But specifics of that, I'll leave to you. With regard to the recoveries, there are various different recoveries in our surgeries. We have 3 different stages fundamentally. One stage is this, what we call the Google mapping stage, where we're mapping your brain and finding the target. That part is done under general anesthesia. So it's as if you were to have some kind of outpatient procedure, but you'll be a little bit groggy when you leave, but you'll go home that day. And then there are 2 other procedural parts. One is where you're awake in the surgery and you usually stay overnight. That actually doesn't hurt so much because, like we said, the brain doesn't have much in the way of pain sensors, and so patients will generally leave the next day. And then the 3rd surgery that we do, where we put the battery pack in, that gets to be a little bit more ouchy. It's not intolerable, but I wouldn't say that it tickles. And those patients also tend to stay overnight, but many of our patients who feel like it, and especially in these times of COVID, they sort of say, I'd rather go home and I'd rather just take care of myself at home. So the recoveries are pretty uneventful, I would say. And then Jill, you see them basically in around about 4 weeks, and then you activate them.
Exactly. So, yep, that's true. And it's not like you need to go to a rehab facility or anything like that post-operatively. You go home, whether it's overnight the next day or the same day, depending on the portion of the DBS process you're in. Question, will DBS offer any improvements in balance? So that's a tough one because the purpose of DBS is to elongate your best on time. So if your balance is improved when the medicines are in your system, then yes, DBS, because it elongates that on time, can have an impact on balance. If your balance is really not impacted by the medicines you take at all, and it kind of waxes and wanes and comes and goes, it may not have an impact. And it is something that we also tell patients, just like balance is a part of Parkinson's that you have to continue to work with through physical therapy, with DBS, you will still have to work on your balance through physical therapy and things like that. Would you have anything to add to that?
Yeah, no, you're right, Jill, because I think that some parts of balance are also with regard to some parts of what happened to do with your stiffness. Like if you're starting to lose your balance, you can't capture your balance because you're so stiff and you fall. So oftentimes patients will think of DBS as a light switch, but I really think of it as a dimmer switch where you kind of fine tune it, and in conjunction with medications, which will potentially likely decrease, but also in conjunction with therapies that I know you're a big advocate of, patients get better. So it's not that you just show up and then suddenly you have this surgery and you're all better. It's a more nuanced process.
Absolutely. And that goes for both procedures as well. These are all things to help manage symptoms more consistently and appropriately. And the basis of how successful either of these will be is based on how well you are already responding to the standard oral medicine of Parkinson's that you take. So these obviously are not first line things. And if you are not having great responses to meds, it becomes a more difficult conversation if either of these procedures are appropriate for managing your symptoms. The one caveat of that is for tremor predominant Parkinson's. Tremor predominant Parkinson's is when the tremor is so pronounced that no matter what medicines that you throw at it, it's just not having an improvement. In that regard, DBS is still considered really the treatment of choice sooner rather than later to treat that particular symptom. As far as the duopa goes, when patients have it, and they do have, I've had patients because they're not wearing it properly, or they get distracted and they place the pump on the table and then they move and it gets pulled. What is the complication of dislodging the tubing, and how is that managed?
Yeah, unfortunately, if the tube gets pulled back in the stomach for whatever reason, because it was not connected properly, or, as you know, there is a outer tube that is in the stomach, and there's the inner tube that goes down further in the small bowel. That tube, the inner tube gets pulled out back into the stomach. Most often than not, the entire procedure has to be repeated to put it back again where it is, where it needs to be.
And is there you had mentioned earlier 2 months to initially after it's placed, if that dislodgement happens prior to that 2-month window, do they then have to wait until things have healed, or can it be done right away?
No, it should be done right away because we can salvage the same stoma, same opening. The 2 months window period is when the tube has to be removed. For example, a patient decides, no, it's too cumbersome for me, I don't want it. 2 months later, we can completely remove it. In 24 hours, the hole will be closed, and in 48 hours, there will be hardly a small scar left.
Gotcha. Also, I get questions sometimes about the level of oozing. What is considered a little bit of normal ooze around the site versus something that needs to be addressed with ointment or medication?
We ask the patients to keep it covered for 24 to 48 hours with the gauze. And after that, actually, there should not be any oozing. If there's a little bit of discharge, it should be no more that it will not cause soaking of the gauze. It will be just barely a stain. So after 48 hours, if a gauze is placed because somebody does not want the friction of the undergarment, friction of the shirt or whatever they are wearing on the tube area, that gauze does not need to be changed for 24 hours. It should barely be a stain. If they are noticing that it's a big stain or it's getting soaked, then it means there's a small infection there.
We got 2 more questions. With DBS, the 6 millimeter target is deep in the brain, it appears. What scenery does the electrode travel past and possibly putting at risk as it travels to the target? What's the risk to the surrounding tissue?
Yeah, so the risk to the surrounding tissue is minimal to negligible. It's really one of the things where it almost sounds counterintuitive. It seems like your brain is definitely this hollowed structure, and of course it is. But there are areas, and the way that the tube goes through it really pushes fibers away rather than transects fibers. So the scenery, so to speak, that it goes through is a neuroanatomist's sort of a garden of Eden. It's going through the cortex. It's going through things called the thalamus, the zona incerta. But those are just really things that I don't think patients ever really have to know. But the thing that you need to know is that in distinction to the way that Parkinson's disease was handled before DBS, deep brain stimulation, or what we call neuromodulation, DBS is exactly that. It's modulatable. And that means that, for instance, in the old days, there used to be what was called a lesion, or we used to do what were called lesionectomies. Let's say in the part of the brain called the thalamus, you'd literally burn it or freeze dry it or somehow caustically take out part of this network structure. But that was it. Then that was gone, and it could never be sort of reclaimed. The nice thing about DBS is that if there were ever a reason that somehow the targeting were off, it's not as if tissues are lost or tissues are now irreversibly damaged. So I think that there's a lot of upside to this kind of therapy.
And how long will DBS last? I've heard 15 years. What happens after that? Does the device need to be removed?
Yeah, so I think that the reason for that is, again, all this is really kind of young if you think about it. Even the dopamine miracle was literally in 1961 in Vienna. So it's only 60 years that we've had L-DOPA. And then Parkinson's, I think the FDA approved Parkinson's in 1997. So that's not a very long time either that we've been working with this. So the reason why we don't have good long-term data, it's kind of a little bit like the vaccine with COVID. Well, we just have only had it. And so there's no way to really know. We don't have people that have had these implants for over 30 years. In general, most of the studies go out to about 10 years because those are, at least at this point in time, the patients that we've collected. But it's not as if you get 10 years and then suddenly everything stops.
And I would say that from a practical point of view, DBS is something that can help reset the clock. So when you have the procedure done, if you're somebody that has been on high dose of meds or slowly been ramping up your meds, if you're on a higher dose, we have more of a window that we can reduce. So you sort of reset the clock and how much medication you need. If you're somebody that had been ramping up, we may be able to keep you where you are and not have to ramp up, but the disease still progresses under the procedure. So it's not that it ever stops working. It's always giving a therapeutic benefit for whatever reason it is that you decided to get DBS. But over time, will you have to bring on board more medicine or try different medicines if newer medicines become available? Because it doesn't get to every symptom that Parkinson's disease can present with. So it's not that it stops working, it's just that you still have to manage the progression under the procedure that's done. Another question that we got, if my family has a history of stroke, would DBS increase my possibility of having a stroke?
No, not at all. I mean, stroke is very different. Stroke is happening on the inside of the blood vessel. It's happening with components that are more biologic, whereas DBS is a mechanical device. If you're worried about can DBS cause bleeding, it's one of the risks, let's say. Dr. Zamir was saying that, for putting any kind of invasive procedure has a risk. I would say that the overall risk for infection with DBS is probably about 1%, and overall risks for anything going awry are only in the range of about 2 to 3%. So that's really great. It's low, but it's of course not zero. And it's certainly I've put enough catheters in over these last 20 years that I have not seen a hemorrhagic stroke occur because of DBS.
And you had mentioned before that it's modulatable. That's one of the things that is the benefit of the therapy of DBS. We now have multiple platforms that we can use through Medtronic, through Boston Scientific, and through Abbott. From a surgical perspective, is there anything that is different about each of them, or are they all typically implanted in a similar way?
They're all typically implanted in a similar way. I think the real nuance comes back to you, Jill, because some of them have to do more with the programming. And I would tell patients not to get too concerned over one or the other. I wouldn't say that this is like you're going out and you're trying to figure out if you want that new electric Ford Mustang or if you want just a regular diesel car or combustion car. If you really have a very strong opinion over one of the companies, that's perfectly fine, and we'll help you with that and we'll accommodate that opinion. But I think the bottom line is that it's surgery. So measure twice, cut once, put it in the right spot. And then the second bottom line is excellent programming, which, Jill, that's what you supply the patients with.
Yes, that's my job. So yes, getting to the idea that modulation. So talking about the scenery that it travels through the target. Some of the potential side effects that come from DBS, changes in speech, impacts on balance, stuff like that, do come from the surrounding areas of what you hit because of that sphere of influence of stimulation. So what the other devices are now offering is more targeted directionality of that stimulation. So in theory, it is something that can help if you are experiencing a sensitivity to the stimulation that you're getting, so you can make it a little bit more narrow, a little bit more focused. It is helpful because it's there, but again, it's not necessarily something that's absolutely necessary to have a good outcome with DBS. It's just the evolution of what the technology can do. And then as far as there's only one company that does the duopa, and that's AbbVie. So Dr. Zamir, is there, I know they have their own tubing and their own connectors and their own device, but if a patient was somewhere where that tubing and connectors weren't available, are they still able to have it replaced with something that could still work?
So we do have what we call gastrojejunostomy tubes by other companies, and they go down as far as the AbbVie tube goes down. But I think the problem may be the connectors to the pump. I think that's probably trademarked and patented by AbbVie at this time. I have not seen it by another company. So the inner tube part can be any company, but the outer ones probably I don't think are available by any others.
Yeah, and I would say that that's what I've experienced as well. Like if someone is somewhere where AbbVie tubing was not available and they had to get it replaced with something else, it does work. It's just a little bit of a hack for the connector part of it. So it just makes it easier if we could get that the AbbVie tubing from the get-go. That's why if we're discussing getting a procedure done like duopa or something like that, I work closely with Dr. Zamir because he has all of the equipment that is necessary to do it. If patients will come to me and they'll say, but I have my own GI doc. And I say, well, that's good, but they don't necessarily have the same equipment or the same, follow the same process that we have that's set for this type of device. So that's why it's necessary. Same thing, a back neurosurgeon is not a functional neurosurgeon. So even if you've had, a lumbar laminectomy in the past, it doesn't mean that that's who you would go back to have your DBS implanted. So
That being said, Jill, I can handle their spine work.
He can do that too, but for the purpose of what I was saying,
But in general, you're right.
Yeah. So training matters,
Yes.
and I don't know if we have any other questions, and we're coming up on the hour. And would either of you just like to say anything else in closing about the procedures that you do?
Dr. Zamir, do you want to start and then I'll finish?
Nothing more than what I already have said. As I said, that in the hospital time is about two hours or so. Patients walk out on their own. Once they go home, they can continue with their routine activities. The recovery time is, less than 18 hours for normal activities. By next morning, they are ready to do whatever they want. And something does not go right, we are available to take calls and to bring them back to the office or to the endoscopy suite next day to address it, but that is very unusual.
And what I would say, Jill, is that I think that the notion of brain surgery fundamentally sounds scary, but is actually something that I would say we can demystify. And I don't think that DBS anymore should be thought of an action of last resort, but I really do feel that it's something that we can think of earlier and earlier in the disease process of our Parkinson's patients to give them more functional livelihoods than just at the end when they might be a little bit more deconditioned and decompensated.
Absolutely. And we got two last questions, which are great to end on. Are side effects of meds increased by duopa? And the answer to that is possibly. So if it depends on the rate of continuous infusion that you have going for the pump, it depends on your sensitivity to medicines prior. So if you were somebody that couldn't take very pulsatile dosing, but tolerated low doses really well, but more frequently throughout the day, and that just wasn't a sustainable schedule to do, that's something that a duopa infusion might be very helpful with. But if even at low doses, more frequently, you're still having potential side effects, then it might not be the right type of intervention. And then for both technologies, what if something goes wrong after hours or on the weekend? So both technologies, whether it's DBS or duopa, have a 24-hour coverage. So in the DBS world, they have their device reps that are able to be contacted, and it's slightly different from pharmaceutical to a medical device, that they have a lot more leeway in the medical device world to be able to contact patients, talk through patients, troubleshoot things with patients. And I will tell you that they are a lifeline for me, especially if there's questions about the device itself, or reading the patient programmer or things like that. So there is a very strong support network in that regard. And then for duopa, they have what's called Duo Connect, and that is made up of individuals through the company themselves, as well as nurses. And the nurses can help triage. They'll come in and out of the house if you need, when the procedure is newly implanted, to go over how to flush the tubing, how to manipulate the connectors, things like that. And then after that, they're still available. They're available by phone 24 hours a day to be able to troubleshoot any questions or concerns. And then, of course, I'm available. And if I'm not on call 24 hours, 24/7, but somebody from the group is. And if there was ever a question or concern and I wasn't on call that particular time, they can easily get in touch with me. And for both of the procedures as well, a DBS and duopa, they have patient ambassadors. So if we've piqued your interest and this is something that you would like to learn more about, and you don't just want to take our words for it, which is understandable, you want to talk to somebody that's living with it, you can contact either, and they will set you up with patients that have had the procedure. They're not paid consultants or anything like that. They're doing this because they believe in the devices and that they want to be able to share their experiences. And you can get the good, the bad, and the ugly of what it's like to live with it and go through the procedure and how their symptoms have been impacted, for the good, for the bad, whatever it might be. And I strongly encourage people to do that, as well as if you have questions for me, I can put you in touch with former patients that have had the duopa placed, as well as the DBS placed by Dr. Sarkar, and you can talk to them as well. So that's it. We are just at 1 o'clock. I want to thank everyone for logging in, and I want to thank you both for joining me for this hour. I hope you all found it helpful, and I appreciate your time.
All right. Thank you, everyone. Bye-bye.
Have a great weekend. Bye-bye.